the cerebral aqueduct, and inferiorly it is going to communicate with the central canal of medulla oblongata. Here we can also see the rhombic lip that is going to determine the direction of the cerebellum. So we can see that this dotted structure this dotted structure is the roof of the fourth ventricle, and it is going to be bounded posteriorly by the well-grown cerebellum in the adult body. Yes. So coming to the next slide, we can see here the schematic diagram on the left side, and on the right we can see the actual cadaveric representation beautifully checked by the Rhoton. We can see here this is the cavity of the fourth ventricle. In mid-sagittal section, it is triangular in shape. Posteriorly, it is bound by cerebellum. Anteriorly, we have the brainstem. This is midbrain, this is pons, and this is upper part of the medulla oblongata. So in the schematic diagram, it's much easier to understand. We can see this triangular cavity or this tent-like cavity on the mid-sagittal section that is completely filled with the CSF, communicating superiorly with the cerebral aqueduct and communicating inferiorly with the central canal of the medulla oblongata. And we can see that the roof of this cavity is going posteriorly into a notch that is known as the cerebellar notch, or we can say that this part is the fastigium. Fastigium is the part where the superior slope of the roof of fourth ventricle joins the inferior slope of the roof of fourth ventricle. So this is the base or floor of the fourth ventricle, and these two slopes form collectively the roof of the fourth ventricle. So in roof, we have two parts, that is superior lateral part, or we will simply refer it as superior slope, and the lower part that is known as the lower slope. So moving forward, uh, here we can see the roof from below, like we are inside this tank and we are looking from below upward. So we will see this superior slope of the roof of the fourth ventricle and inferior slope of the roof of the fourth ventricle. And this part, like I explained earlier, is the fastigium that demarcates the junction of superior roof, superior slope and inferior slope of the roof of fourth ventricle. Or we can say that this part is the fastigium that is shown horizontally right here. So if we see a little bit closer to the roof of the fourth ventricle, we are focusing on the superior slope. We can see that medially it is formed by this green structure, that is the thin membranous layer that is known as the superior cerebellar, superior medullary velum, and laterally it is bounded by superior cerebellar peduncle. Or we can say that the roof of the fourth ventricle is laterally formed by the superior cerebellar peduncle, and between these hang this whitish membrane that is known as the superior medullary velum, and it is going to connect to the fastigium, and from the fastigium uh, distally we will have another structure, another thin white sheet that is known as the inferior medullary velum. So this is the nodule of the cerebellum, like we are viewing from below to the above, to the roof of the fourth ventricle. We can appreciate this is the roof, and this is giving rise to thin white membranous structure on the either side that is known as inferior medullary velum. So this was about the lower slope proximal part, and if we talk about the lower slope inferior part, this structure is known as the telocoroidea. So before we go to actual cadaveric anatomy, let us explain what is telocoroidea. Basically, we know posterior to the fourth ventricle, we have cerebellum, and this green lining shows the pia mater of the cerebellum. So it is actually the pia mater of the cerebellum that goes upward, upward, and upward till the notch of the cerebellum, and then it reflects upon itself, and at this level, this collective layer, this double membranous layer of pia mater is known as the telocoroidea, that is responsible to contain choroid plexus within it, and we all know choroid plexus produces CSF and it communicates with the cavity that we are going to discuss later on. Or we can here see these structures, these red structures. We can say this is the pear L-shaped structure, or some would say it is T-shaped structure. These are the choroid plexus. These are responsible for production of CSF inside the cavity of the fourth ventricle, and we can also appreciate that these paired structures of the choroid plexus are going laterally as far as the lateral recess of the cavity of the fourth ventricle, and hanging down and hanging laterally into the cerebellopontine fissure through the foramen of Lashka. We all know that the CSF from the fourth ventricle drains into subarachnoid space via two lateral foramen. These are known as the foramen of Lashka, and one median foramen that is known as the foramen of Magendie. So this is the schematic diagram. I hope it will help in upcoming slides when we actually see the cadaveric models of the fourth ventricle. So this beautiful diagram showing the triangular cavity uh, is fourth ventricle mid sagittal section. As we can appreciate, this vertical surface will be floor of the fourth ventricle. Superiorly, it is formed by the pons. Inferiorly, it is formed by the medulla oblongata. Whereas we can appreciate this structure, this superolateral margin, or we can say that this superior slope is forming the superior part of the roof of the fourth ventricle, and this inferior slope, this structure going down here, is forming the lower slope of the roof of the fourth ventricle. This is the middle cerebral peduncle. So let's make it a bit easier. Yes. Uh, this highlighted structure we know as the middle cerebellar peduncle. This is superior cerebellar peduncle that is forming the lateral margin, or we can say that is from the lateral boundary of the superior part of the roof of the fourth ventricle, and this forms the inferior cerebellar. This shows the inferior cerebellar peduncle that is forming the lateral boundary of the lower part of the uh, roof of the fourth ventricle. So this is actually showing the roof of the fourth ventricle. The superior medullary vellum has been cut in order to show the superior cerebellar peduncle. So this is the roof of the so this is the upper slope of the roof of the fourth ventricle, and then there is lower part, proximal part of the lower slope of the roof of fourth ventricle that is formed by the inferior medullary vellum. And like I explained earlier in the schematic diagram, it is continuous beneath with the tila choroidea to form the lowermost part of the lower slope of roof of fourth ventricle, and these woolly structures inside the tila choroidea are nothing but choroid plexus. So this is the mid sagittal section. Now we will proceed to uh, the foramen. We can see here, this is the foramen of Magendie. Like I explained earlier, when uh, the lower slope of the roof of the fourth ventricle has aperture or has an opening in the midline, that is known as the foramen of Magendie, and we have also lateral opening through the lateral recess through which the cavity of the fourth ventricle opens laterally into the cerebellopontine fissure through which the CSF escapes from the fourth ventricular cavity into the subarachnoid space. So this is lateral fissure, lateral recess, or the opening of the foramen of Lashka. Here we can see more clearly. This is the cavity of the fourth ventricle open for our understanding, and this highlighted portion of the diagram shows the lateral recess of the fourth ventricle. So this is about the mid-sagittal section. Now we will proceed to understand the anatomy of the roof. Again, when we are going to visualize the roof from below upwards, we can appreciate this is the superior cerebellar peduncle forming the lateral margin of the upper slope of roof of fourth ventricle, and between we have hanging structure, white matter, white thin membranous matter, that is known as superior medullary vellum, and beneath we have inferior medullary vellum forming the lower slope proximal part, and then tila choroidea that contains the choroid plexus. Now we are going to see the actual cadaveric model of this diagram. In order to visualize the roof of the fourth ventricle from below upwards, we are going to compromise brain stem of a cadaveric patient. Uh, Hi, Imad, are you there?
Imad, can you help, please?
What
I
happened?
want to, yeah, I want to remove this admitting bar or see waiting remove option from my screen so that I can focus on the slide.
It
Can you
cannot be
help me,
removed.
Jessica?
You can just put it on one side. You can make it
Yes.
small and put it on one side.
Yeah, it's done. Thank you. So, sorry for the interruption. So this is the beautiful brainstem cadaveric model. We can appreciate here the midbrain. This is the pons. This is medulla oblongata. This is uh, pontomedullary circus. This is pontomesencephalic circus, and these are the respective cranial nerves that are originating from their respective regions in the pons and the medulla oblongata. That are not our primary focus here. We are going to focus on removing the pons and medulla oblongata left portion in order to visualize, in order to have a better understanding of the roof of the fourth ventricle. So we have removed the pons and medulla oblongata. We can appreciate this is the upper slope of the roof of fourth ventricle. Then we have fastigium, that is the demarcation, that is the joining between the superior slope and the inferior slope of the roof of fourth ventricle. Now, if we zoom it out, we can see clearly here, this is superior medullary velum, like we explained in the schematic diagram. Median portion of the upper slope of roof of fourth ventricle is formed by
Sorry, Uzair,
superior.
what are you showing? We can't see what you're showing.
This is actually, we are actually visualizing the roof of the fourth ventricle
Sure.
from below upwards. We
Yeah,
have compromised, we have
I think sir,
dissected.
you have to reshare because some of people cannot see your slides. I can see, but no, other people cannot.
Later on, we have furthermore
Uzair,
magnified.
Uzair, can you hear
Yes,
me? Yeah,
yes,
you have to reshare your slide. Stop slide share, then reshare your
yes.
slides.
Okay. Please let me know where to.
I can see the slides. Let me ask the participants if they can
Yeah,
see.
keep going. Keep going. Just check with everybody. Everybody can see.
Yeah, they're saying now it's visible.
Okay. So one more. Yeah, this is where we were at the end.
Yeah, thank you.
So resuming from here, we can see the beautiful cadaveric section of the brain stem. Here we can appreciate pons, we can appreciate the medulla, its parts, and we can appreciate the pontomedullary sulcus, pontomesencephalic sulcus, and the respective cranial nerves that arise from their respective parts of the pons and medulla oblongata. That is obviously not our focus here. We are going to divide the pons and some portion of the medulla in order to have a better understanding of the roof of the fourth ventricle. So basically, we are inside the tent, we are visualizing the roof from below upwards. So, like I explained earlier in the schematic diagram, the roof, superior slope of the roof of the fourth ventricle is formed by the superior medullary velum, and inferior slope is formed proximally by the inferior medullary velum that is joined more distally by the tila choroidea. And this portion is known as the fastigium. Fastigium is the portion, or fastigium is the region that demarcates the junction of superior slope and inferior slope of roof of fourth ventricle. So this is a magnified view. We can appreciate this is superior medullary velum forming the superior slope of the roof of fourth ventricle in the median portion, and laterally it is bounded by superior cerebellar peduncle. And then we have fastigium, that is the demarcation, that is the highest most, or that is the posterior most part of the roof of fourth ventricle. Beneath the fastigium, we have cerebellar nodule that is going to give rise to thin membranous structure that spread like wings on the either side, and this structure is known as inferior medullary velum, and this is the inferior medullary velum that we discussed earlier is going to make the proximal part of inferior slope of roof of fourth ventricle. Now this is another dissection. We have dissected the inferior cerebellar peduncle on the left side, so we can appreciate the lateral recess of the fourth ventricle. Remember, there are two lateral recesses and one dorsal median recess. So two lateral recesses has two openings that is known as foramen of foramen of Leshka, and one median recess that is known as foramen of Magendie. So we have dissected in order to visualize the lateral recess of the left side. So the lateral recess of the left side is anteriorly bounded by flocculonodular peduncle. We are visualizing again. I would like to emphasize on the orientation. We are dissecting from anterior to posterior. So this is the anterior portion of the lateral recess. Posteriorly, it will be bound by the flocculonodular part. There will be the nodule, and this is the flocculus of the cerebellum. There will be a small peduncle connecting these two structures. So posteriorly, lateral recess boundary will be flocculonodular part, and anteriorly, the anterior portion that we have removed is inferior cerebellar peduncle. Now moving forward, again we are visualizing from anterior to posterior direction. We can see roof clearly here. This is the superior medullary velum forming the median portion of the superior slope. Then we have the fastigium. Then we have inferior medullary velum originating from the nodule spreading on the lateral side, and then we can appreciate the tila choroidea. So tila choroidea form the lowermost portion of the inferior slope of roof of fourth ventricle. And we can see these woolly structures inside the tila choroidea. These are the choroid plexus. Now we have removed the choroid plexus on the right side, so we can see the posterior relation of the roof inferior slope, that is tonsil and flocculus. And now we are going to remove tonsil on the right side, so we can appreciate origin of the inferior medullary velum. So this is the nodule, and it gives rise to inferior medullary velum, that is thin membranous structure, non-nervous tissues on the either side. This is known as inferior medullary velum, or we can appreciate more clearly after we have dissected out almost everything in the lower slope of the roof of fourth ventricle. So moving forward, so this was approached just to understand the anatomy of the fourth ventricle. Obviously, it is not advisable to dissect out the brain stem of any patient. The actual approach to the fourth ventricle is from the behind. So we are going to discuss in detail. So these are the suboccipital surfaces. We can see the cerebellum here and the vasculature here. And to tease out ourselves, we have removed the vasculatures. We can appreciate different cerebellar structures. This is the pyramid, this is uvula, the upper part of vermis. Now, if we apply traction on the left tonsil, we can appreciate inferior medullary velum from behind. Now, this is the approach from the behind. We are approaching the roof of the ventricle from behind. And this is inferior medullary velum, and these are the tila choroidea. One thing I would like to emphasize is that when we are doing a posterior approach, we are approaching the fourth ventricle via lower slope of the roof of fourth ventricle. As I mentioned earlier, the roof of fourth ventricle has a superior slope and an inferior slope. While we are approaching fourth ventricular cavity, we are going through the lower slope only. So in the lower slope, if we visualize, we can see inferior medullary velum is forming the proximal part of lower slope, whereas tila choroidea is forming the distal part of the lower slope of fourth ventricle. And we can appreciate the foramen of Magendie, that is in the median region in the lowermost portion of the tila choroidea. So after dissecting it out, we can appreciate this is inferior medullary velum on the either side. This is vermis and uvula. This is tila choroidea. Within embedded in it are choroid plexus responsible for CSF production, and then we have foramen of Magendie through which the CSF escapes the fourth ventricle into the subarachnoid space, in this case cerebello-medullary system. Now going ahead, we can appreciate this section. This is uvula again. This is inferior medullary velum on either side, and this is the tila choroidea. And this junction where the This junction in the lower slope of the roof of fourth ventricle, where inferior medullary velum and tila choroidea meet, is known as the telovelar junction, and it is a very important approach in getting into the fourth ventricular cavity, remove tumors and such things. So this is basically telovelar approach. We have removed the tila choroidea completely from both the sides. So we are visualizing the cavity of the fourth ventricular from the lower slope. So this structure is actually the upper slope of the roof of the fourth ventricle. We have, again, I would like to emphasize that we have opened up the roof of fourth ventricle from the lower slope. And in this diagram, in this cadaveric model, we can see that we have opened the lowest portion of the lower slope of the roof of the fourth ventricle. So we can uh, see the superior slope structures. This is the superior cerebellar peduncle, and somewhere here would be superior medullary velum forming the superior slope of the roof of the fourth ventricle. And this is actually the floor of the fourth ventricle. And this small structure, if we can appreciate, will be the cerebral aqueduct communicating the cavity of fourth ventricle proximal to the cavity of the midbrain. So making our life easier thanks to Rhoton, we can appreciate this diagram step by step. We have applied the cerebellar retractor. On the other side, these are the cerebellar tonsils. This is uvula of the vermis. These are the choroidea. Now we have applied retraction on the left cerebellar tonsil. We can appreciate some structures here. These are the cerebellar tonsils, like explained earlier. This is the vermis of cerebellum. This is uvula of the cerebellum. This is inferior medullary velum, which means it is the superior portion of the proximal part of lower roof of fourth ventricle. This is tila choroidea. Like I explained earlier, it is the double reflection of pia mater from the cerebellum onto the lower slope of the roof of fourth ventricle. And these woolly structures inside the tila choroidea are nothing but choroid plexus that are responsible for the formation of CSF. So this is all about the anatomy of roof of fourth ventricle. So this is another diagram showing the dissection. We can appreciate this is cerebellar tonsils, this is uvula, this is inferior medullary velum. These are tila choroidea. Within it we have choroid plexus. We have removed the tila choroidea and the choroid plexus from the left side. Now we can go into the floor of the fourth ventricle. Then there will be cerebral aqueduct. This is the superior cerebellar peduncle forming the lateral part of the superior slope of the roof of fourth ventricle. Now I'm going to highlight it number one. This is superior cerebellar peduncle. Like I explained, this is superior lateral part of lateral recess of the fourth ventricle. And this is the floor of the fourth ventricle. And then we can appreciate this structure as cerebral aqueduct. Now, going to discuss about the floor of the fourth ventricle. Like we discussed, the hindbrain is known as the rhombencephalon because it is going to give rise to a cavity that is rhomboid shape. So we know the floor of the fourth ventricle is rhomboid in shape. We can see here. So this rhomboid floor, rhomboid fossa, or sometimes it is referred as calamus scriptorius, that I am going to explain why it is known as calamus scriptorius. So we can appreciate this is middle cerebellar peduncle. So it is there, but it is not forming any boundary or part of the floor of the fourth ventricle. We can appreciate this is superior cerebellar peduncle. This is inferior cerebellar peduncle, augmented medially by the cuneate and gracile tubercle of the medulla oblongata. Here we can appreciate median sulcus. This is the cerebellum retracted sideways. So it's quite difficult here to discuss the anatomy of the fourth ventricle. So let's proceed to a schematic diagram that will make our life much easier. This is the schematic diagram of the floor of the fourth ventricle or the rhomboid fossa. We can appreciate this rhomboid fossa is divided into two vertical triangles by this line that is going all the way through the floor of the fourth ventricle, or we can appreciate here, this is known as the median sulcus. So this line that divides the rhomboid fossa into two vertical triangles is known as the median sulcus. We can also appreciate this white matter band that is dividing these rhombus into two upside down triangles. This structure is known as stria medullaris. So this structure here we can see is known as stria medullaris. This structure demarcates the junction of floor of fourth ventricle. So above this stria medullaris we have the pontine part of the floor of the fourth ventricle, and below this we have the medullary part. We are going to discuss the content of the pontine part and the medullary part of the floor of fourth ventricle. So coming to this diagram, we can appreciate this is the superior cerebellar peduncle forming the superolateral boundary of the floor. This is inferior cerebellar peduncle that has been divided in order to show the contents of floor itself. This is the middle cerebellar peduncle, and now we are going to discuss this rhomboid fossa itself. So this is the median sulcus going all the way from above down to the level of central canal, this median sulcus, and lateral to this median sulcus we have another sulcus known as sulcus limitans. Lateral to the medial sulcus we have sulcus limitans, and between these two sulci we can appreciate this eminence, this elevation on the either side is known as medial eminence. The significance of this medial eminence is that it demarcates the position where facial colliculus lie. So what is facial colliculus? Facial colliculus are actually the motor nerve fibers of seventh nerve that are winding around the abducen nerve. Like I would like to make you remember that this is the pons, and it will have the nuclei of its respective cranial nerves. So this medial eminence has this facial colliculus, which is actually the winding of the motor nerve fibers around the abducent nucleus. Now we can see the sulcus limitans here. At the upper portion of the sulcus limitans, we have smaller depressions that are known as the superior fovea. And similarly, the sulcus limitans, when it goes into the medullary part of the floor of the fourth ventricle, it has inferior fovea. So this is the superior fovea and this is inferior fovea, just lateral to the sulcus limitans. Another important structure just above the superior fovea is locus coeruleus. What is locus coeruleus? Locus coeruleus are the deep pigmented bluish discolored cells due to melanin content that are responsible for noradrenaline production in response to stress and panic. As we would like to recall, these are the circumventricular organs. This is the part of brainstem that is responsible for the panic and stress attack. So this is the locus coeruleus. It contains specialized cells. These are known as substantia ferruginosa, which are responsible for the production of noradrenaline in response to panic and stress attacks. So, and lateral to this sulcus limitans, we can appreciate this area. This is known as the vestibular area that refers to the vestibular nerve, and we can also appreciate that this vestibular area comprises both of the pontine part as well as the medullary part. Now, I think the above triangle, the pontine portion of the floor of the fourth ventricle is all complete. Now, coming to the lower portion of the triangle, that is the upper portion of medulla oblongata. Like we discussed earlier, this sulcus limitans is going all the way down in order to meet the median sulcus in the medullary triangle. When this sulcus limitans meets the sulcus limitans of the other side and the median sulcus in between, we can appreciate two small triangles formed here. So these triangles are known as the hypoglossal trigone or hypoglossal triangle. on the either side. And beneath it, we have another small triangle that is known as the vagal triangle. All these triangles having the cranial nerve names in it, we can understand that these refers to the nuclei of these cranial nerves. Now, if we look closely to this schematic diagram, we can appreciate a very faint sulcus. This is known as the funicular separations. It is very hard to visualize it in actual cadaveric model. This funicular separations demarcates the junction of vagal trigone with the area postrema. Area postrema is actually the true vomiting center. It's a chemoreceptor region in the brain. It is also a type of circumventricular organ that is responsible in the brainstem for the vomiting. So it is the true vomiting center of brainstem. It is just beneath the vagal triangle. So we have discussed so far the schematic diagram of the floor of the fourth ventricle. It is rhomboid shaped. Upper portion laterally bounded by superior cerebellar peduncle. Lower portion inferiorly is formed by inferior cerebellar peduncle, medially augmented by cuneate tubercle and gracile tubercle. Another important structure are the tinea. These white structure, which we can appreciate in this schematic diagram or in this diagram more clearly, is actually narrow bands of white matter that are going all the way down in order to meet the same structure of the opposite side. These are known as the tinea. So when they meet each other, this point is known as the obex, or we can say that obex is the lowermost point of the roof of fourth ventricle, or we can also say the obex is the point where fourth ventricular cavity communicates with the central canal of medulla oblongata. So now actually moving to cadaveric model now. Now it would be easier after schematic diagram. We can appreciate this diamond-shaped cavity, floor of fourth ventricle. These transverse structures, very faint white structures are stria medullaris, demarcating the junction of pontine and medullary part of the floor of fourth ventricle. Then we can obviously not miss this median sulcus that is dividing this rhombus into two vertical triangles. And lateral to median sulcus, we have sulcus limitans, very faint here. And between the sulcus limitans and the median sulcus, we have this medial eminence that is the region of facial colliculi. And what were the facial colliculi? Facial colliculi were actually the motor nerve fibers winding around the abducent nerve nucleus. And then lateral to the sulcus limitans, proximally we have superior fovea, and above the superior fovea we have this bluish discoloration region known as locus coeruleus, containing substantia ferruginosa, responsible for formation of noradrenaline in response to panic and stress. And now coming down, we can see beneath the stria medullaris, sulcus limitans is going to meet the sulcus limitans of the opposite side and the median sulcus in between. So we have two small triangles formation. These are known as hypoglossal triangle. And beneath the hypoglossal triangle, we will have vagal triangle, and uh, beneath vagal triangle, we can appreciate area postrema that is uh, separated from the vagal triangle with a very faint sulcus known as the funiculus separations. And this area postrema is the true vomiting center of the brainstem. And then we can also appreciate the tinea of the two sides going to meet here, and this junction is known as the obex. Like I explained earlier, it demarcates the uh, lowermost part of the roof of the fourth ventricle, or we can say that fourth ventricle ends here and central canal starts here. So moving ahead, this is fourth ventricular cavity. We can appreciate the lateral recess, median sulcus here, medial eminence, facial colliculi. This is the sulcus limitans. There will be locus coeruleus, superior fovea, inferior fovea, hypoglossal trigone. Let's again make our life easier with the help of Rhoton. So this is median sulcus. This is abducent nucleus, and around there is binding known as the facial coeruleus. Then we have in the lower part of the fourth ventricle or floor of the fourth ventricle, we have hypoglossal trigone, and beneath it we have vagal trigone, and behind it we have the true vomiting center known as area postrema. So this is the area postrema. So this is all about the floor of the fourth ventricle. Uh, it's time to revise a little bit the structure I explained about the roof and floor of the fourth ventricle. So this diagram. So can any participant voluntarily answer what is this structure shown in this mid-sagittal section of the fourth ventricle?
Please raise your hands if you want to answer.
Anyone?
Can you ask the question again? Let's see, Rupesh is again taking the lead. We unmute Rupesh.
Sir, it's inferior medullary velum.
Yes, exactly. It is inferior medullary velum, and it is forming the lower slope proximal part of roof of fourth ventricle. Excellent answer. So moving on to next slide. What is this? It's an easier one actually. Any volunteer?
Okay, raise your hands. Okay. So we have Abhishek. Yes, Abhishek.
Lateral medullary recess.
Sorry?
It's lateral medullary recess.
Yes, exactly. It is lateral recess of the fourth ventricle. And going
Okay.
on to next slide. It's a little difficult one, isn't it?
Okay. We have Parvat Kumar here. Yes, please.
It is superior cerebral peduncle.
Sorry, unfortunately, it is not superior cerebral peduncle. I would like to show superior cerebral peduncle. This is the superior cerebral peduncle. I would like to emphasize that we are reaching the roof of the fourth ventricle, but we are reaching the lowermost part. We are reaching the lower slope of the roof of the fourth ventricle. So if we open up the lower part of the roof of the fourth ventricle, we can visualize superior cerebellar peduncle here. This is the superior cerebellar peduncle. This is something else.
Okay, so we have Rajesh. Yes, please.
That is the inferior peduncle.
Exactly, excellent answer. This is inferior medullary velum, like I explained earlier. Inferior medullary velum is a thin membranous structure that arises from the nodule of cerebellum, and it forms the proximal part of lower slope of roof of fourth ventricle. So if we are going to open up the roof of fourth ventricle from the lowermost part, like we are going to remove the tila choroidea and the choroid plexus, we will have inferior medullary velum right here. So inferior medullary velum is the correct answer. And what is this structure?
Okay, we have Hina. Yes. Hina, yes, go on.
This is hypoglossal trigone.
Exactly, excellent answer. This is hypoglossal trigone that is in the lower part or the medullary part of the floor of the fourth ventricle, and behind it we will have vagal trigone, and behind it we will have area postrema. I think that's all for the quiz.
Azam, do you want to make any comments here, please?
Yeah, unfortunately, I have a case at the
No worries.
to start. So I think it was a very good presentation. Just a couple of points. The first one was that if we look at the quote unquote safe entries to the brainstem or entry zones, which is oftentimes what's important, unless there's a fourth ventricular, a tumor just involving the fourth ventricle. In these cases, you know, there's a number of different quote unquote safe entry zones. One specific to the fourth ventricle, the one through there's the one through the floor of the fourth ventricle. It can, most often people do this midline, and then they can also be in, you know, either the paratrigeminal area or near the lateral recess. So anything can be done, but if you're balancing risk, a much better approach, if it's feasible, is through the middle cerebellar peduncle. It's a very robust way to approach lesions in the brainstem, and it's very, very well tolerated. Even if the lesion comes seemingly to the surface of the floor of the fourth ventricle, you may say, oh, it's right there, and you have to go through a lot more of the middle cerebellar peduncle to get to the lesion. I still prefer that, because almost invariably there's issues with, as careful and as you are going midline, almost always people develop cranial neuropathies from approaching it through the floor of the fourth ventricle, unless the tumor has created the corridor for you. For instance, in a dorsally exophytic type of a tumor, something that comes into the fourth ventricle, you can see it's clearly situated within the fourth ventricle, and then has extended from the brainstem into that location, or purely fourth ventricular pathology like a hemorrhage or ependymoma, something like this, can be well approached through the floor of the fourth ventricle. Otherwise, middle cerebellar peduncle far and away is the best approach. And by doing that, you can also extend it into foramen of Luschka. You can open the telechoroidea by the choroid plexus and widen that corridor even further if you need to, and it's very, very well tolerated. So that's one of the most important points. The second important point is indications, and you know, there's a number of reasons why we do this. Obviously, there's tumors, there's hemorrhages, and other things. But one of the important things, and we all learn this through experience, particularly from our mentors, is when you have a large compressive fourth ventricular pathology, and the patient comes in with a terrible exam, that exam is obviously flavored and occurs because of the compression of the brainstem. So in these cases, I've had a couple of patients who had an exam consistent with brain death. Okay, so these guys were not overbreathing the ventilator, no cranial nerve reflexes at all. And if you have a large compressive fourth ventricular lesion, you go take that lesion out, and these patients can make a good recovery. So I would say that in the appropriately selected patients, that it's important to do that, and not to say, well, the patient's exam is so terrible, there's no hope for recovery. The second thing is hemorrhages within the pons, pontine hemorrhages. Another common reason to consider approaches, or another common pathology that people say, well, these patients are going to do terribly. It really depends on the size of the hemorrhage, and more importantly, its location. Is it located ventrally in the pons or dorsally? Dorsal pontine hemorrhages tend to be much better tolerated than ventral ones. And those dorsal hemorrhages, in some select cases, we've gone in and removed those, and the patients have done well, even when they're large, like 20 ml volume hemorrhages. I have a current patient in the hospital right now where we did that. And she's following commands in all four extremities, anti-gravity strength at least. She does have, obviously, cranial neuropathies involving extraocular movements, swallowing dysfunction, other things, but she's only 45, and so I think she'll make a reasonable recovery. The final point is, there's many points to make here, but one other point that I'll leave you with is that what's critically important when you determine how best to approach the lesion, and this is probably the most important thing I'm going to say, is to consider the long axis of the lesion. It's more important, and no matter where we're operating in neurosurgery, supratentorially, infratentorially, but critically important in the brainstem. Very rarely is the lesion perfectly spherical. In most cases, it's oblong, ellipsoid, And in those cases, approaching it down the long axis is very important. So that's the first best place to start, is where does that long axis project to the skin? And if you start your approach with that philosophy, you'll go a long way in selecting the right approach in the vast majority of circumstances. So when that long axis takes you via from inferiorly through the fourth ventricle through tilovelar tonsillar approach, that's fine. If it takes you through middle cerebellar peduncle, that's fine also, or through the inferior superior colliculi. All of these are very reasonable ways to approach the lesion, as long as you go down the long axis. The reason why that's important is that if you approach it from the orthogonal way, you have to make a very long opening in the brainstem in order to achieve your goal of resecting that tumor, evacuating that hemorrhage, or what have you. So the long axis is critically important. Oftentimes the tumor or the lesion creates the corridor for you, so you can utilize that as well. Some things that may not be easily achievable, for instance, it's very hard to see the cerebral aqueduct if you do a tilovelar tonsillar approach inferiorly if there's no pathology dilating that fourth ventricle open for you. But if the pathology has opened the corridor substantially, then it's often very much easier to see up that high. The last point is that these approaches, depending on how you do them and where the pathology is located, it's often helpful to do them in occasionally in a sitting position as well. It's not commonly done, but sometimes the angles and the trajectories can be helpful that way, as opposed to, leaning on the patient and obliquely turning your neck in order to look from an inferior to superior view. So I'm sorry, I would have some other points, but I have to head off to the OR. Sorry about that.
No, Azam, don't worry. I think we will have you. We have brainstem anatomy coming up next week. So that is going into detail about brainstem anatomy. So we have Pablo and Miguel Erez, who recently. So we're going to have good fun with them, and I'm sure we'll have you over and
that
get
sounds
your
great.
Comments there.
That is a very good presentation. Well done.
Thank you, Azam, and thank you, Uzair. Wonderful job. Sorry, Azam, that we dragged you away from your theater, but I think it's
no problem. Thank you.
Thank you. Cheers.
Thank you, everyone.
Okay, I think we move on to Yusuf. Yusuf is our chief resident, who's going to be talking about clinical implications of this fourth ventricular approaches. Yes, Yusuf.
Okay, so can everybody see the slides?
Yes.
Okay, so today I'll just be talking about the clinical application or the approach to the lesions of the fourth ventricle. And most of it is just going to be the anatomy revision. So if you have heard, or if you have from the answers what I have seen so far, all of you guys have done very well in the anatomy. And if you know the anatomy, then the clinical approach or the operative corridors would be very easy for you. Because we are going to discuss only the tilovelar approach, so I'll not be taking much of your time. So there should be certain concerns when you're approaching the floor of the fourth ventricle. Now, the important element is that you may cause some deficits, particularly if you injure the structures in the floor of the fourth ventricle, because we just saw that the floor of the fourth ventricle contains the vagal triangle, the facial collicula, so a number of cranial nerves are present. In the past, what they used to do was they enter the fourth ventricle by splitting the cerebellar vermis. Although this was fairly well tolerated, the post-operative results were usually not that good. Hence, with the identification of the fissures around the fourth ventricle, which largely include the mesencephalic fissure, pontomedullary fissure, they identified that opening the tila choroida alone can provide very good exposure of the fourth ventricle, even without the need to split the vermis. And the inferior medullary vermis, velum, which we talked about multiple times, which is again a thin paper layer, can also be opened if the tila choroidal opening is not sufficient enough to provide adequate exposure. So this is just again a revision, a diagrammatic representation. This is what we talked about in the previous session, which was the infratentorial supracerebellar approach. This is the tilovelar approach. Again, this is a tilovelar approach directed towards the midline. This is the sagittal view showing the fastigium, and then this is the lower half of the fourth ventricle. So a telovelar approach is generally considered for lesions involving the lower half of the fourth ventricle. However, with the angle trajectory, you can address some proximal lesions as well. The reason it is called telovelar approach is because it is this junction that we are utilizing, the junction between the tela choroida and the inferior medullary velum. So the basic advantages is that the tela, opening the tela alone itself provides good access to the full length of the floor of the fourth ventricle and even up to the fastigium, the superior-lateral recess, which can also be accessed. And if you combine it with the opening of the inferior medullary velum, then the lateral area and the superior half of the roof can also be easily accessed. And you can continue your dissection laterally so that the foramen of Liaquat can also be identified and opened. This is particularly important for treating certain form of ependymomas, which tend to grow through the foramen of Liaquat. So, clinical perspective, be very careful of the anterior structures because occasionally the tumor within the fourth ventricle will distort the anatomy. It will push the inferior medullary velum, the tela choroida, posteriorly. Incising those structures is not going to cause any deficit. In fact, incision of these structures will create the corridor to remove the lesion. But if you take the incision too deep and you damage the structures anteriorly, that would not be acceptable because there is risk of injury to the dentate nuclei, cerebellar peduncles, the floor of the fourth ventricle, which contains most of the cranial nerve nuclei, as well as the pica, which are at risk. So we have talked about the anatomy, the important anatomical structures around the lesion. So let's move on to some radiology. So I'm sorry, I don't have the contrast images. I picked these images from the internet. They do not belong to me. You can appreciate that this is the fastigium, this is the upper half of the fourth ventricle, and this is a lesion in the lower half of the fourth ventricle. So this would be an ideal approach for a telovelar approach. A telovelar approach would be addressed like this. Again, what would be the position? A position would be obviously prone, concord position in order to have good venous drainage. This position is good, but because you are accessing the lower half of the fourth ventricle, neck extension is going to make exposure of this part difficult. Hence, this is a better position in which the flexion of the neck will provide good exposure and will also open the C1 and C2 because in most circumstances, you will need to do a C1 laminectomy as well. So in this procedure, what is the intraoperative monitoring that you would like to do? We'll be coming on to that. Again, real-time presentation of the image, a prone positioning, midline incision, which is from the inion down to the level of C4, C5. Monitoring of the seventh cranial nerve, it is important because in the floor of the fourth ventricle, we have the facial colliculus, then the lower cranial nerves, 9, 10, brainstem auditory evoked response, and somatosensory and motor evoked potentials. This is the monitoring that you need to do. So once you have given the incision and you have performed subperiosteal dissection, this is what you're going to get. Now, this is the cranial end, this is the caudal end. So you're looking at it from the side, that is from the microscope. So this is the occiput, this is the occipital bone, this is the C1 which is exposed bilaterally, and this is the C2. Between the C1 and C2 and occiput and C1 are the membranes. So you have performed the craniotomy, you have removed the bone, you can appreciate the cerebellar tonsils, you can appreciate the dural covering, you have removed the C1 lamina, you can identify the atlanto-occipital membrane, and you have also removed upper half of the C2 lamina. So this is the atlanto-occipital membrane, and these are the cerebellar tonsils covered by intact dura. Now the atlanto-occipital membrane has also been removed. You can appreciate the clear, shiny dural covering. So now you are going to incise the dura, usually in a Y-shaped fashion. Once you do that, this is what you're going to get. These are the two cerebellar tonsils. You have reflected the dura right and left with the help of silk suture. What you can appreciate here is the arachnoid. You need to open the arachnoid. Once you open the arachnoid, you get an excellent visualization of the anatomical structures. Again, the cerebellar tonsils. Here, you see the tumor which is bulging through the fourth ventricle, the pica present on both sides, and this is the spinal cord. So the next element is perform gradual dissection. In order to have better exposure, you need to open the cerebellomedullary fissure. So on this side, on the left side of the lesion, you are going to do the opening of the cerebellomedullary fissure. You need to use microscope, you need to use micro scissors, and with adequate exposure, only with adequate exposure, you will be able to remove larger lesions. If we go up, we identify the tila choroida. We open the tila choroida in the midline so that both the tonsils can be further retracted, providing good exposure to remove this particular tumor. So once you have incised the tila choroida, open the fissures, you perform blunt dissection with the help of dissector, or number 6, you can perform gradual dissection of this lesion. You can perform internal decompression. The normal principles of tumor removal apply. That is internal decompression followed by extracapsular dissection. Once you have removed the lesion, you perform a good neuroplasty and then you close the lesion. So this is just about it about the telovelar approach. This is one of the most common approaches that we see when addressing the lesions of the fourth ventricle, particularly in the case of children who present with ependymoma, medulloblastomas. And having covered the anatomical aspect, there was not much to be explained clinically, because if you know the anatomy, your obvious clinical exposure would be very easy. And in surgical perspective, one of the major problems that we come across is the first step, that is the positioning of the patient. Always spend a little more time in positioning of the patient, because if the position is wrong, the rest of the procedure is going to be very difficult, or you will be struggling with the ergonomics of the case. So always make sure that the position is right, spend some extra time making adequate positioning, and once that is done, the rest of the procedure is based upon your anatomical landmarks, and I'm sure you all will be able to do that well.
Good job, Yusuf. I think that was a very good summary of the telovelar approach. I think what has happened is basically over time, we have stopped using the Vermean approaches, and we are going more and more telovelar because it's much safer doing it. Unless you've got a localized lesion, which by going telovelar, you may cause problems. So unless in those cases, otherwise we generally recommend that. The other thing what we have done over time is where exactly the lesion is extending to. So your position will change, how much of neck you're going to flex, or how much of leverage you need to go on the right, on the left, depending on where the lesion is going. Obviously, we do things accordingly. So it's generally very helpful for us because by going through that, you're going through a normal anatomy and you're slowly and gradually entering into the danger zone. And by doing that, everything becomes much easier, and the surgery is easy, and you're able to have landmarks. It's like when you go to a place where the surroundings, and automatically from different points in those surroundings, you're able to see where exactly you're going. So I think over time, slowly and gradually, that has come up. We will discuss this again when we discuss brainstem anatomy and approaches. I'm not sure we have that talk in about, I think 4 or 5 days time, that we have brainstem anatomy and approaches. I think one of Miguel Reyes is going to do the brainstem anatomy, and Pablo Gonzalez is going to go through the approaches of the brainstem next week. So thank you guys, it was wonderful. If you have any questions, please feel free to ask. In the meantime, what we could have a group photograph, which, Ahmad, are you there?
Yes, sir, I'm ready.
If you can show us what we have lined up for next few days, and then we can have a group photograph and see if we can get everybody on the screen if possible. Show us what we have. Okay, so we are starting the module 2. In module 2, we're going to have 3 sessions, and session 1 will be on phylogenetic evolution of brain and surface anatomy. And this will be done, go back, by Pablo Gonzalez from Spain. He will present this particular session, although he's a consultant, but he wants to present himself. We will have Azam, Hasan, and Deopujari, plus our chief residents would be there helping him with this talk and discussion. To follow that up, yes, Ahmad, can we move on? We have tomorrow Hasan Syed from Brigham and Women's Hospital in Boston. talking about deformity, and Onur Yaman from Istanbul. Actually, he's moved from Koç University. He's not there anymore. He's moved to another university. So he will be giving a talk on sagittal balance. Next, please.
I have this right now.
Okay, all right. So no worries. So can we all switch on our cameras and see if we can get how many people we can get on the screen? Ahmad, can you try fitting everybody?
We can get 25 at a time. So that's not an issue. I can take multiple pictures.
Okay.
Okay. So everyone is requested to see in the camera and with a smile, so I can take that picture. Thank you.
Smile, everybody. Where are you? Are you done?
I'm taking pictures. 1 second. Yeah. Thank you, everyone.
Thank you. Did you get everybody?
Yeah.
Okay, brilliant. Good job. So we will see you all tomorrow, same time.
Okay.
All right.
Sure.
Thank you, everybody. Uzair, good job. Yusuf, great work. I think Azam did very well by going through all the tips and tricks. And we will have some more coming in.